Now, this slide depicts pretty much all that we have ever known: acute services and elder care disability services as siloed systems functioning fairly independently from one another, with very expensive care transitions that take people back and forth, usually literally in ambulances. Rehospitalization and related care transitions are forcing a more articulated relationship between hospitals and elder care disability services and home care in particular. And of course, there's a deeper challenge here, and that is how to create a more integrated healthcare and health assistance system that is as focused on caring as it is on curing, and where long-term care is as important as inpatient care. So what would it look like if acute care services were seamlessly integrated with elder care disability services? And what if regional economic development could rely on robust ecosystems of caregiving structures and systems and institutions, including the bedrock of a healthy and stable care force? Could it be that caregiving infrastructure is as essential to a well-functioning economy as roads and bridges? So let's remind ourselves about why direct care workers are so important to the caregiving structure that we need. It's because they're deployed every day in several million homes and in hundreds of thousands of facilities and day programs around the country, because 8 out of every 10 hours of paid services delivered to elders and people with disabilities are provided not by a doctor or nurse, but by a direct care paraprofessional. Direct care workers are also important because they're extremely well situated for observing and reporting changes in their clients' conditions. They're ideally positioned to work in care teams, to interface with family caregivers, and to support positive health-related behaviors. In other words, direct care workers are uniquely embedded in the lives of their clients. Now, of course, this has always been true, and I think what's changed is the underlying demographic and economic fundamentals, which I would argue have reconfigured the value of direct care workers to this group of 4. For policymakers, investing in a better trained and adequately supported direct care workforce is a cost-effective use of taxpayers that can bring down turnover and public benefit costs while reducing direct care workforce shortages, and investing in smart care models that capitalize on the unique embedded position of direct care workers offers the prospect of system-wide efficiencies and cost savings. For local communities and regions, investing in these jobs creates significant local economic impact. For health system managers, direct care workers, again, are an untapped source of innovation and a potential source of efficiencies and cost savings. And for families and employers, a greater supply of direct care workers who are supported in their work can help alleviate the personal and social costs of caregiving. So I think that care work in America today is at a crossroads, and we can continue with the status quo, adding direct care positions that are poorly supported and poorly compensated, or we can leverage the direct care workforce for what it is, an enormous underutilized asset in our healthcare and health assistance system. Preparing America to care. At PHI, we think that moving forward to realize the full potential of the direct care workforce requires policy development not in 10 areas or 6 areas, but in 4 important areas. The first is reforming government payment policies to reward the creation of quality direct care jobs. And what that means, first and foremost, is designing effective payment methods that encourage minimum standards for direct care worker compensation in public programs. The second area is training. We need to modernize our country's approach to direct care worker training by enhancing training content using competency-based curricula, setting consistent standards that go across occupations that require similar skills, extending federal hourly training standards, and finally investing in state training infrastructure. We also need to design and promote new models of care that expand the role of direct care workers who care for older adults. There are nascent models already under development out there, for example, for continuing care workers or advanced aides who can move across settings and who work in interdisciplinary teams while addressing the needs and concerns of family caregivers. And finally, we need to advance caregiving infrastructure innovations that support consumers and their families and also workers, particularly in decentralized models of service delivery where consumers self-manage their care and hire their own direct care workers. For example, web-based registries or matching services can support consumers and workers to find each other and can be linked to other intermediaries that provide access to things like training and emergency backup services. In closing, for me, this is a truly exciting time to be working on these issues, in part because I think the common ground for alignment is broad and deep, and in large part because the economic arguments for investing in better caregiving infrastructure are so compelling. Thank you.